then a review class. So I will need candidates. So I think we have 4 candidates: Dr. Mona, Dr. Asma, Dr. Umama, and Dr. Hina. Am I right? So
Yes.
Yes, sir.
great. So we'll start. Who will take the first case? Dr. Asma?
Okay, sir.
Okay, great. Okay, so you got this patient in your clinical exam. So this is a 2-year-old girl with outward deviation since 6 months.
Okay, sir.
Can you comment on the photos?
Yeah, sir. This is a photograph of a child and showing movements in primary gaze and in the right gaze and the left gaze. In the primary, if I comment on the middle photograph, that is in the primary gaze, the eye seems to be slightly exotropic. Even yes, it's very slightly. And in the right gaze, however, the right eye abduction seems to be okay, but in the left eye seems to be hyperdeviated. And same is the case in the left gaze. That is, the left eye abduction is normal, but the right eye seems to be so hyper elevated in the adduction. So to me, the most probable diagnosis in this case is bilateral inferior oblique overaction
With exotropia.
with exotropia. Yes, sir.
So when exotropia accompany with inferior oblique overaction, so what pattern do you expect?
With inferior oblique overaction and the exotropia, ulcer is basically it's
Type of pattern?
A pattern.
V
No.
pattern.
No, sorry, V pattern. Sorry, it will
Yes.
be
So
converging in the downward gaze and diverging in the upward. So it's V pattern.
definitely. So this patient, we are expecting that she will have V pattern exotropia. So to say that the patient is having significant V pattern, what is the difference between the up gaze and down gaze measurement should be,
It
at
should be
least?
yeah. So it should be more than at least it should be more than 10 to 15 prism diopter.
So for V pattern, 15 prism diopter. For A pattern, only 10 prism diopter. Difference between up gaze and down gaze.
Okay.
Okay. So this patient came to you in your clinic. How would you approach the patient? What would you do for her?
Okay, so if this patient comes to me, she's of 2 years of age. The first thing I will do would be the cycloplegic refraction of this patient, and will try to find about this, give best corrected visual acuity, and I will also look for if there is any strabismus is present, and if it is there, would do steps to strabismus management. I will first do, and I will also look for any compensatory head posture or head tilt. And if there is like a binocular single vision is present and there is no complaint as such with that, then even I can keep the patient under observation. And if there is compensatory head posture is there, and when I measured the deviation with the prism bar, and it seems to be, first I will note that down, and I will keep the patient on a follow-up, and if on the follow-up I would find it to be deteriorating, then in that case I would go for some surgical management for two, and that will be bilateral inferior oblique weakening procedure. And because it's an A pattern, and for the exotropia A pattern,
V
I
pattern.
would like,
Pattern. V pattern.
sorry, V pattern. Why do I always saying A? It's a V pattern and exotropia. So in that case, I will do the vertical component also by and the medial rectus will be directed or transposed towards the downward gaze, and the lateral rectus in the upward, along with
But
the
do
inferior.
you need to do vertical transposition of horizontal recti in this patient?
Yeah.
Do you
So,
do that?
sir, I will do it along with the inferior oblique weakening procedure.
No need, actually. So in a patient with V pattern or A pattern, if the patient is action, then you will go for the vertical transposition of the horizontal recti, but you don't need to do both together.
Okay. Okay, sir.
Okay. So in this patient, we have +4 inferior oblique overaction, actually. That is grade 4 inferior oblique overaction. So in this patient, you just need to do inferior oblique surgery. That will be enough to collapse the V pattern and to treat the pattern, along with bilateral LR recession, as you mentioned, to correct the exotropia.
Okay.
But as I mentioned before in previous classes, it's very important when you are having a case of strabismus to mention first thing in such patient, pre-verbal patient, you need to check the fixation preference. If the patient is having, for example, right constant exotropia or left constant exotropia, so you will need to do patching therapy. So the patient will have alternate fixation. That is one thing. Secondly, if the patient is having significant refractive error, then as you mentioned, you will give glasses. Giving the glasses in such patient with exotropia. So if the patient is having myopia, I will give the full correction. If the patient is having astigmatism, I will give the full correction. If the patient is having hypermetropia, if it is mild hypermetropia, usually we don't give anything like +1 or +1.5 or +2. In a 2-year-old, there is no need to give glasses. But if the patient is having moderate to high hyperopia, you need to give partial correction. For example, if this patient had +5 hypermetropia, so I would give +2.5, for example. Okay, so we will give partial correction of the hypermetropia. One more thing you need to mention is I need to examine the anterior segment, posterior segment, because sometimes patient with exotropia or esotropia will have an organic cause, whether retinoblastoma, whether retinal detachment, whether optic disc hypoplasia, whether cataract. So you need also to mention this point.
Okay, sir.
Okay?
Yes. Okay. Thank you.
Great. Thank you, Rasma.
Thank you.
So this is the patient before the surgery and after the surgery. So what I have done, I did bilateral LR recession with bilateral inferior oblique anteriorization or anterior transposition. And I usually use this technique when I am having +4 inferior oblique overaction. And as you can see, the results is good. The inferior oblique overaction improved and the exotropia as well improved. Okay, so sorry, who will take the next case?
I can take, sir. I'm Hina, Dr. Hina.
Dr. Hina. Okay, please comment on this picture, that 9-gaze photo of a 40-year-old female.
Yeah. So this is a 9-gaze position of the front of the upper part of the face, showing 9 position of the gaze. So in the primary position, I can see the right eye is deviated inward, so showing esotropia. And when I come to the right gaze, the right eye is unable to move outward. So there is limited dextro version in the right eye, but left eye is okay. So with the right gaze, and on the left gaze, both eyes they are moving normally. But if we talk about the dextro elevation. So in dextro elevation, the right eye has no action, and left eye is so yes. And then in the elevation, again, their left eye is elevating, but the right eye is not elevating. Rather, it's moving inward and having less elevation. So then in the levo rotation, the left eye is moving right. Yeah, fine. And the right eye has again underaction in the levo elevation. And then in the dextro depression, the left eye again having the normal action, but the right eye has underaction.
Okay.
And in depression, the both eyes, they are depressing, but they are moving not exactly downward, not depressing, they are moving inward. So like showing the hyperaction of superior oblique maybe, and then in the levo depression, both eyes, they are moving yeah, fine. So if we comment overall, so in this levo depression and the left gaze eyes, they both are looking, they are doing the normal movement, the both eyes. So mainly it seems like right eye is affected.
Okay,
Like,
so what's the diagnosis?
So one, yeah, so it's a esotropia, and
In which
they
eye?
right eye esotropia, and it's not like equal in all gazes.
Okay, so what do you think the diagnosis? Give me your diagnosis from the
Uh,
picture.
yeah, so it seems like it's a incomitant.
Yes, Dr. Hina, give me diagnosis, Dr. Hina. I know this is incomitant
Right,
esotropia.
esotropia,
Give me your
and
diagnosis directly. Don't hesitate.
sorry.
Don't hesitate. Just give me the diagnosis, Dr. Hina. I know that you know it.
Okay. So, sir, so it may be this it's the third nerve is mainly affected, isn't it? So all like elevation is problematic.
In third nerve, your esotropia will be there or exotropia will be there if there is third nerve palsy.
Sorry.
If there is third nerve palsy, you
Yes.
told third nerve, no?
Yeah,
So
it's
what
depressed.
do you expect? Esotropia or exotropia in the third nerve palsy?
Exotropia and depressed.
So what is there in this case?
So it's inward moved. So it's
Esotropia is there, no? And there is limitation of abduction, no?
yes, there is limitation
So,
of abduction and also elevation. Depression is
Elevation
fine.
elevation is not affected, but because the medial rectus here is contracted, the eye is not moving well. That is the whole point.
Mm-hmm.
Okay.
Yeah.
So what do you think the diagnosis now after
So,
the hint?
so it maybe the LR problem in the LR, like LR affecting 6 nerve.
Oh, okay. Yes. So this is right complete six nerve palsy. Okay. Right complete six nerve palsy. So thank you for your effort, but I think the way you describe the photo make you more puzzled.
Okay,
So
yeah.
just try to describe things in a simpler form. So first of all, you focus on this picture, the primary position photo. This is the most important one. So I would say this is a 9-gaze photo of a female patient. So she has right inward deviation, right esotropia. With the Hirschberg, it might be around 50 or 60 prism diopter, okay, or 30 degrees esotropia. In the left gaze, left up, left down, it looks okay. In the right gaze, right up, right down, there is limitation of abduction in the right eye in all the photos. And the right eye is not crossing the midline. The right eye is not crossing the midline.
Yeah.
Okay, so this is around -5 limitation of abduction. So whenever the eye only reaching the midline, we call this -4 limitation of abduction. But if the eye is not even reaching the midline, this is more than -4. So this is maybe -5 limitation of abduction. So this is a case of right complete six nerve palsy. So how would you approach this patient?
Sir, how much time did you say that patient had this problem? For how long? In the
Okay,
scenario mentioned?
I didn't mention actually.
Right. So, yeah, so in management, I will take the complete history, like for how long this deviation is there. And uh, uh, is there any history of trauma, or patient is having any diabetes, hypertension, or any other neurological problem along with this deviation he's having? And yeah, so
Yes.
so I will take history and I will examine the patient. I will check the VL acuity, and I will do this extraocular motility. I will check and do the cover uncover test, and I will check the deviation in all nine position of the gaze with the this um, cover uncover with this alternate cover test, and to find out is it committant or incommittant, and then I will do this prism cover test as well, and then just like here in this case I'm suspecting that it's a six nerve palsy, so and it's a paralytic muscle, so I'll confirm with this saccadic movements as well, and also I'll do the post action test to confirm my diagnosis. I can do this head
So,
start.
so saccadic movement and force duction test
Yes.
and another test will help you to differentiate whether this is complete or
In,
incomplete sixth nerve palsy.
okay.
So in this case, even with limitation of abduction of -5, the eye is not reaching the midline, it might be incomplete, right? So what are the things that will tell you that this patient is having incomplete sixth nerve? And what are the things that will tell you that this patient is having complete sixth nerve palsy? How to
So,
differentiate between
so just like we said, if there'll be no abduction at all, like if it's more towards the inward, like from the midline, from the primary, from the center. So it's showing like it has no action at all, and it is all like overcome by the medial rectus. That's why eye is has moved
but
from
what
the point to
other things that will help you? We
that will
have
be post
saccadic.
action vision, saccadic movement,
So yeah. So if
post
the
action.
eye is,
Yes.
is having a abrupt stop, so there might be a mechanical element,
Yes, the
mechanismus contracture. But if it is slow floating saccades, so that goes with paralysis.
analysis
And
is
we have also something called forced generation test. So
where
forced
you
generation
are
test usually is
actually
done.
move towards the affected side. But
Yes.
if
So
patient
yes.
then
So
it's
if there is remaining LR activity, you
Mhm.
will feel the tug of the muscle. If there is no LR activity, you will not feel anything. And force duction test also will help you to see if there is any medial rectus contracture or not. And usually in chronic cases, there will be medial rectus contracture. Okay. So this patient actually had a head trauma 1.5 years ago.
Mhm.
And the esotropia did not improve
Mhm.
through this 1 year and a half. So what are you going to do?
So just like I said, after history complete examination, I have mentioned up till the external examination. So I will do the complete slit lamp examination with the examination of the anterior posterior segment, just to see if there is any other problem or pathology along with
Okay.
this nerve paralysis. And so after completing my examination, I will do the some investigation. Like I can take the help of neuroimaging as well, just to rule out because there was a history of trauma. We
Yeah,
know
yeah.
there is
There is
this.
obvious history of head trauma because the patient developed esotropia.
Yes, sir. So once, yeah, so it's a long-standing one. So here, obviously, all those mayors initially which we do, they are not going to work here. So like the patching we give or any prisms we give initially or the Botox, they are just for the initial management.
Yes,
Less
yes,
so here we
yes.
will go for the surgical
Botox,
management. So
Botox
we'll
will
ask,
not Botox will not work after 1 month of the paralysis
yes,
because after 1 month, medial rectus contracture will start to happen and Botox will not give any improvement.
okay, right.
Yeah.
So surgical management, then because it's a complete sixth nerve palsy. So we will do the medial rectus recession, and for the LR, because it doesn't have any action at all. So we have to transpose it either with the Hamilton procedure or with the Jensen. So in Jensen, we just join the muscle belly with the lateral rectus. So we divide the muscle belly of the superior and inferior rectus and join them with the lateral rectus muscle. And in Hamilton, we actually split the muscle tendon, the superior and inferior, and we transpose their half on the top and on just below on the top part and the below of the lateral rectus. The lateral rectus muscle.
Great, great. Yes. So in patient with complete sixth nerve palsy, there is no point to do LR resection or strengthening procedure because, as you mentioned, it is not working at all. So you need to do transposition surgery along with medial rectus recession because usually in these cases, the patient will have medial rectus contracture. So medial rectus recession plus transposition. Transposition, as you mentioned, Hammersheim or Jensen or superior rectus transposition or modified Nishida. There are many transposition surgeries, but what you have mentioned are the most important ones that usually they are asking about. Okay, thank you so much, Dr. Hina. Okay, so who will take the third case? Any volunteer for the third case? Dr. Muna, Dr. Wafa.
Yes,
No,
Dr.
okay.
Okay, Dr. Wafa
Yeah.
will take the case. Okay. Okay. So this young child came to your clinic. Comment on the photos, please.
Okay. In the primary position, I can see slightly the right eye exotropic by Hirschberg test. On the right gaze, there is a hyper elevation of the left eye on adduction.
Okay. What else?
On the left gaze, there is downshooting of the right eye on left gaze and normal abduction of the left eye.
Okay. Great. What else? Anything else? Dr. Wafa, anything else you want to add?
There is also palpebral fissure narrowing of the right eye on
Attempted adduction. Yes.
yeah.
Okay. Great. So as you mentioned, the patient had small right exotropia in primary position. There is limitation of abduction in right gaze. The eye is not moving out to the maximum. You can see here the sclera. Am I right? So if you can see the sclera, that means the eye did not move to the maximum. So the patient is having right limitation of abduction.
Abduction.
Yes. And here the patient is having right downshoot, severe downshoot, with mild limitation of adduction as well, with narrowing of the palpebral fissure. So what do you think the diagnosis of this patient?
Right Duane.
Okay, so right exotropic Duane, or according to Haber classification, this is type 3. Why type 3? Because patient is
There is
having
limitation in
abduction and
abduction.
adduction.
Yeah.
Both are limited. So in type 1, we have only limitation on abduction. On type 2, we have only limitation on adduction. On type 3, we have limitation in both abduction and adduction. So in this patient, what would you do? How would you approach this patient?
First, I will see his vision, the best corrected visual acuity. I will do cycloplegic refraction, and I will see if the patient has any preferred eye to fixate with. After that, I will see if the patient has any abnormal head posture in a primary position, any diplopia in a primary position, and I will proceed according to that.
Okay, so let's say the patient had 6/6 vision in both eyes and cycloplegic refraction revealed only plus 0.5 diopter sphere, and fundus examination, everything else is great. So what would you do for this patient?
If his vision is normal, I can do a surgical intervention for abnormal inferior shooting. And if there is abnormal head posture, I can do either inferior, I do either medial rectus and lateral rectus recession for the contraction and narrowing of the palpebral fissure, or I can do Y splitting of the lateral rectus with vertical muscle transposition. Also for the upshooting, I can do fade-in procedure.
Okay, so in this patient, she had exotropia and downshoot. So we can do lateral rectus recession with Y splitting, both in the same muscle. We can do lateral rectus recession for exotropia and Y splitting for the downshoot. So that will take care of both things. For limitation of abduction, we can do much, but at least we will correct the exotropia, will correct the downshoot. So generally speaking, in patient with Duane syndrome, always counsel the family that you cannot correct everything. You can ask them about what is the most bothering things that they are bothered about, and you can work on this, but you cannot correct everything altogether in one procedure. Okay. One more thing, in patient with Duane retraction syndrome, sometimes patient might have anisometropia, patient might have high hypermetropia, patient might have amblyopia. So you need to treat all these before doing the surgery. And in some patient, we don't do anything. If the patient does not have anomalous head posture, orthotropic in primary position, we can just observe. Okay.
Okay, for this patient, as he's almost ortho in a primary position, can we only
We can
observe?
we can observe, but actually the patient had exotropia. She had small exotropia in primary position. So if the family is bothered about exotropia, if there is amblyopia because of this exotropia, we can do surgery for this small exotropia by tackling lateral rectus muscle, doing LR recession, as I mentioned, with Y splitting to correct the downshoot as well in the same procedure. But for some parents, if they are not keen for the surgery, we will give glasses, we will treat amblyopia, and we will follow up the patient every 6 months. Okay. Okay. So who would take the next case? Dr. Muna?
Yes.
Okay,
Can I
great.
join?
Yes. Okay. So this is 5-year-old boy. This is his primary position picture. And this is the up gaze, right up, and this is left up. So can you comment on?
Okay, on primary position, the left over right, left hypertropia and right hypertropia. And on up gaze, in middle image, there is a defect of elevation in the right eye. On the up and out, there is a defect in elevation as well, but in the left gaze, there's defect of elevation of the right eye.
Okay. So you commented on this picture, and this picture. What about this picture?
Yeah, I see there is a defect in elevation in the right gaze of the right eye.
Okay. Okay. Do you think that the limitation here is like the limitation here, or it is more in...
No, on the left gaze more than right gaze.
Okay, so the right eye limitation of elevation is more on adduction than abduction. So
Yeah.
what do you think the diagnosis of this patient?
For differential diagnosis, mono elevation deficit
Okay.
of the right eye or Brown syndrome, but
Okay.
because the an abduction, there's some elimination of the elevation, so I think there's the Brown syndrome.
Mm-hmm. Yes. So
Yeah.
actually, this is the right Brown syndrome. Here you can see there is -4 limitation of elevation. Here, maybe -3 to -4. Here, it's -1, maybe -1.5. So the limitation of elevation is much better in abduction than adduction. So that is a case of Brown syndrome. So for Brown syndrome, how would you classify Brown syndrome? Classification, yes. So we have a classification according to the etiology and classification according to the severity. So how would you classify?
According to etiology, I think there is congenital or acquired.
Yes, exactly.
But I don't have any idea about the other classification.
So for the congenital, usually either we have a short superior oblique tendon or inelastic or a thick superior oblique tendon. So the tendon is not going through the trochlea smoothly. Because of that, the eye is not going up freely. So that is for congenital. There is an anatomical problem in the superior oblique trochlear complex. And regarding the acquired, we have many causes like inflammatory, rheumatoid arthritis, and other immune diseases, or iatrogenic. For example, if you did for a patient with superior oblique, you did superior oblique tucking and you did so much of tucking, so you can give the patient Brown syndrome. Or if a glaucoma surgeon put a glaucoma valve, and because of the valve, there is a restriction in the superior oblique muscle, so that again can cause Brown syndrome. Or a retinal surgeon put a scleral buckle, and again that scleral buckle did restriction in the superior oblique muscle, so again that leads to Brown syndrome. So either inflammatory or iatrogenic or infectious or traumatic. Traumatic like the canine tooth syndrome. Okay? So
Okay,
that
thank you.
according to the etiology. According to the severity, any idea, Dr. Muna?
No.
So like any other disease, you will just classify to mild, moderate, severe. Very simple. Mild, moderate,
Okay.
severe. So in mild Brown syndrome, usually we have only limitation of elevation on adduction. That's all. In moderate, we have limitation of elevation on adduction with downshoot. Okay. And in severe, we have also a hypotropia in the primary position. So any patient with hypotropia in primary position, we consider it as a severe Brown syndrome. And And how would you approach this child with congenital Brown syndrome? What would you do for this patient?
Firstly, for their history, and there is examination of the visual acuity and the best corrected of visual acuity. If there's any cyclorefraction, then if there's like this, there's in primary position there's hypotropia or disfiguring in the I will do it's the indication for surgery.
Okay, so
After anterior posterior examination and dual examination. Yeah.
After doing your full workup, anterior, posterior segment, cycloplegic refraction, best corrected visual acuity, check the preference, make sure that the patient has no amblyopia or significant refractive error. And as you mentioned, the indications for surgery in patient with Brown syndrome, either hypotropia in primary position or anomalous head position or disfiguring downshoot of the eye on a deduction. So in such cases, we can do surgery. So what type of surgery can be done?
Superior oblique tenectomy.
Okay,
or
that is yes.
Okay, or elongation of the superior oblique tendons.
Yes, exactly.
Tendon. Yeah.
Yes. So either you will do superior oblique tenectomy, so you will cut the whole tendon. But the problem with this surgery, what can happen after this surgery? Superior oblique tenectomy or tenotomy. What can be done after the surgery?
Inferior oblique overaction.
Yes, superior oblique palsy action. So the patient, rather than having hypotropia, he will have hypertropia after the surgery. So that actually happened in patients with superior oblique tenotomy or tenectomy. In 25% of the patients, 1/4 of the patient will develop overcorrection. Because of that, we usually now prefer to do a lengthening procedure, as you mentioned. We have many lengthening procedure, whether silicone expander or something called split tendon or suture spacer or the other name chicken suture. So all these are options to do superior oblique tendon lengthening to treat Brown syndrome. One more question. Intraoperatively, you need to do a test to confirm Brown syndrome. What is that test?
Force adduction test.
If that test came to be negative intraoperative.
Negative means the inferior oblique, maybe inferior oblique mass palsy.
Or any other thing. Yeah. So to confirm diagnosis of Brown syndrome, FDT must be positive for superior oblique. That is one of the criteria for the diagnosis. If it is not positive, it is not Brown. Okay. Regarding acquired Brown syndrome, usually we do not do surgery. We can do medical treatment, either systemic steroids or systemic non-steroidal anti-inflammatory drugs, or giving triamcinolone or betamethasone injection in that trochlear, either systemic steroids or giving trochlear injection of triamcinolone or betamethasone. Okay. Thank you so much, Dr. Muna.
Thank you.
So we have Dr. Angeli. Can you participate with us, Dr. Angeli? Dr.
Yeah, please
Angeli.
volunteer, Dr. Anjali, or other candidates, please. This is just a mock exam, please.
Yeah, it's totally fine. We are just discussing the cases. So this is the way you will get to know how to diagnose the cases. You need to try. Okay, Dr. Asma,
Yeah, sir, I can take it.
thank you. Okay. I will give you a brief history about the patient. This is a 30-year-old male who had multiple pterygium surgery in the left eye.
Okay, sir.
And after 3 pterygium surgeries, he developed inward deviation of the left eye. So
Yes, sir.
comment on the picture, please, and then we will discuss.
Okay. This is a picture of a young man and showing 9 position of gazes. In the primary position, which is the middle photograph, it shows uh, left eye esotropia around about 40 to 45 degrees. And in the right gaze,
40,
the movement,
45 degrees or 45 prism diopter?
sorry, 45 prism diopter. And in the right case, the right and left eye, their movements seems to be okay, normal. Whereas in the left case, the right eye adduction is normal, but there is limitation in the abduction of left eye. If I grade it, it can be grade 2 or grade 3. In the right elevation, both the movements are okay, and in the left elevation, there is limitation of elevation in left eye. And
Okay.
similar in the depression, in the right gaze, in the depression, there seems to be normal movement of both eyes. However, in the right eye seems to be a little limitation, but in the left eye it seems normal. And in the left lower gaze, there is again limitation of the left eye in the abducted position. And in the midline, in the simple elevation and the simple depression, there is in the left eye, there is more elevation in adduction. And in the down gaze, it seems to be more inward movement, especially in the down gaze too. So, on looking at and assessing this different gazes, the main pathology lies in the left eye, and there is limited abduction
Okay.
and limited elevation in abduction, limited depression in abduction. So
Okay.
it's basically
With the history of pterygium surgeries?
yes, multiple these pterygium surgery seems to be done on the nasal side of the in the horizontal gaze. So medial rectus muscle seems to be involved, and so it causes maybe there is a mechanical restriction
Exactly.
in
Yes.
in the or there can be a trauma to the belly of the muscle.
Actually,
And
if trauma happened, you will get exotropia. If, for example, the surgeon that did pterygium surgery, he cut the
yes,
medial rectus, you will have exotropia with limitation
yes,
of T deduction. And
yes, sir.
that is actually one of the common scenarios of pterygium surgery. But this one is uncommon scenario with pterygium surgery where the patient is having esotropia. And here you can see what is this?
So this is yes, this seems to be this is a pyogenic granuloma.
Yes, this is pyogenic granuloma. So
Yes.
actually, there is a restrictive process around the medial rectus.
Okay.
So that patient had esotropia post-regime surgeries,
Mhm.
and intraoperatively he had a lot of adhesions, fat adherence, everything mixed together, the conjunctiva with the tenon, with the fat, with the muscle. So I managed him doing medial rectus recession with lateral rectus resection. And after doing the medial rectus recession, there was no enough conjunctiva to cover the area. So we did conjunctival autograft
Mhm. Yes, sir.
and also amniotic membrane graft to cover the whole defect, because there is severe conjunctival shortening, and the conjunctiva is shortened, and very small amount of conjunctiva to cover the area. Okay,
Okay, sir.
thank you so much.
Thank you so much.
Okay, so who will take the next case? Dr. Hina?
Yes.
Okay, great. Okay, so this gentleman came to the clinic with complaints of diplopia, binocular vertical diplopia. So,
Mhm.
can you comment on the photos?
So yeah, this is the photo of the upper part of the face in the 9 position of gaze. In the primary position, I can see the right eye is left eye is hypertropic. Yes, slightly hypertropic. And then coming on to the right gaze, if I see again, the left eye is hypertropic in right gaze, and same in the dextro elevation and in the dextro depression. So left eye is hyper throughout on the right gaze. And then if we come to the elevation, still left eye is hypertropic. And in the depression, again, so there is limitation of the depression again in the left side. So right eye is fine in all gaze in the right sided, and also in the up and down. Uh, yeah. And then when we look on the left gaze, yeah, there is slight here, hypertropia again, slight here in the left eye. And when we are looking in the left up gaze, so levo elevation, again, there is here elevation if we compare it with the right here. And same in the uh, levo depression. So,
Yeah.
so yes, sir, is a hypertropia, which is getting, yeah, that's what I can say. Otherwise, apertures, they look normal. It's just the hypertropia, which is in the left eye.
What
So,
could be the diagnosis in this patient?
so it could be that hypertropia could be because of this. Again, it could be because of the problem in the left eye. The depressors are affected, but it could be the right eye elevator. They have problem. So then here I have to do that park test.
Yeah,
See
I
park test.
agree. I agree. But from this picture, we have 3 signs that will help you.
Okay.
First, left hypertropia, as you mentioned.
Yeah.
There is left inferior oblique overaction. It's
Yes.
very prominent.
Mhm.
And there is superior oblique underaction. When you
Yes.
compare
Yes.
here, there is
Yes.
limitation of depression on A deduction and
Mhm.
over elevation of A deduction with
Yes.
left hypertropia. So we can say it could be left superior oblique palsy.
Yes, sir.
As you mentioned, with 3-step test, you can confirm the diagnosis. I agree with you. Okay, so how to differentiate between unilateral and bilateral superior oblique palsy?
Okay. So just like in this case, we are looking. So one eye is hypertropic in primary. So usually with the unilateral problem, the hypertropia will be evident in the primary gaze. But in case of bilateral, usually both eyes, they will be orthotropic, and there might not be any tilt and the face turn, but we can see the chin down because the depression will be affected. So patient will have compensatory head posture like chin down in case of bilateral. That's what we can see in case of, but in unilateral, just like here, we are looking in primary position, there is a hypertropia in the affected eye, left eye, and also in obviously here, yeah, there is, we can't comment on the compensatory head posture. Probably
What,
patient,
what is
but
the expected anomalous head position in this patient?
so opposite to the side of pathology. So if it's a left side, so a patient will be head will be tilted toward the right side, and face will also be turned toward the right side.
The patient will have right head tilt.
Yes, sir.
Great.
Opposite to the.
So as you mentioned, to differentiate between unilateral and bilateral, firstly, in unilateral, usually you have head tilt opposite to the side of the palsy. In
Yes.
bilateral, usually we have chin,
Yes, chin depressed.
chin depression. And secondly, as you mentioned, in unilateral, usually we have large hyperdeviation in the affected eye. But in bilateral cases, usually we have smaller hyperdeviation. Sometimes we have asymmetrical palsy, so you might have hyperdeviation in one of the eyes
Okay.
if the patient has asymmetrical bilateral superior oblique palsy. But if the patient has bilateral symmetrical SO palsy, there will be no hyperdeviation in the primary position. Okay, that is the second thing. Great. What else to differentiate?
Yes. So after, so then obviously I will take the history, and I will do heat examination. So in
Sorry,
history,
Dr.
sorry, sir.
Dr. Hina, I'm sorry. We need to complete the differentiation between unilateral and bilateral. We
Okay.
didn't finish.
Okay, right. So yes, sir. So I will again, just like I said, so I will turn the face towards the right side. So in right and left gaze, I will see. So if it's a like a bilateral, so that hypertropia will increase on that side. So if it's a like in both sides, so both eyes
Yes.
they will get hypertropia. So right will get hypertropic more on the right, and the left will on the left. So in case of bilateral, this will happen. But in case of unilateral, this hypertropia gets worse
Yes.
only when the patient will turn. So we'll get that boog. So worse on the opposite gaze.
Yes.
So it will be worse on the opposite gaze, like in the right gaze in this case.
Yes. What you have mentioned in bilateral cases, we call it reversal of hypertropia. So in
Okay.
right gaze, you have left hypertropia. In right gaze, you have
The in the right gaze, the left hypertrophy will get worse.
in right gaze, right hypertropia. In
Yeah,
left gaze, left
left,
hypertropia.
left gaze,
Okay?
sir.
Okay. Also, to differentiate between unilateral and bilateral, in bilateral, usually we have V pattern esotropia.
Yes.
And also, when you are measuring the excyclotorsion, if the excyclotorsion is more than 10 degrees, that is suggesting bilateral. If it is less than 10 degrees, that is suggesting unilateral. And also, when you are examining the fundus using indirect ophthalmoscopy, if you are having unilateral fundus extorsion, this is unilateral. If you are having bilateral fundus extorsion, this is
Uh,
bilateral.
right.
Yes. Now continue, Dr. Hina, regarding the history and the approach for this patient.
Okay, but when I will take the history, so I will keep in mind the causes. So I'll ask about is this deviation present since birth or when it has started. So that will give me a clue of, is it congenital idiopathic or is it acquired. So in acquired, then I will ask about any trauma, about the trauma or any vascular like any vascular lesion can be there or any but the most common are trauma and the microvascular in case of fourth nerve. So I can ask the history about the diabetes, hypertension, but I will to rule out, I will ask about any other focal neurological deficit or any body weaknesses. And then in examination, I will check the vision and I will check the vision and I'll do this extra motility examination, the cover, uncover test, and the alternate cover test, and the prism cover test to check is this deviation is equal in all cases or is it varying to differentiate between the paralytic and the committant, committant incommittant. And then I will do this saccadic movements when I'll check the extraocular motility to differentiate between paralytic and the this restrictive myopathy. And
Yeah.
yeah, and then also force duction test just to confirm my diagnosis. And I can take the help of that test chart if it's available. And then I will do some investigation just to rule out what I have said, like the causes. So I can take the help of a neurologist. So I'll co-manage with them, with the help of them. So I can do the investigation. I can take their opinion, and then I will see, like, if patient has this problem for a long time, like more than 6 months. So then definitely, and if patient is having any diplopia in the primary position or in the down gaze. So there I have to, within the 6 month, I can do these, maybe the patching to overcome this diplopia or this prism I can prescribe. But after 6 months, definitely I have to go for the surgery.
Okay. Before going to the surgery, how to differentiate between congenital and acquired fourth nerve palsy? So those are the two most common questions regarding SO palsy. How to differentiate congenital versus acquired and unilateral versus bilateral. We answered the first one, unilateral, bilateral. Now, let's answer the congenital versus acquired. How to differentiate.
So the congenital patient usually have this compensatory head posture, and also they have this vertical.
Even acquired, they might have compensatory head position.
Yes, but this vertical deviation, that will be more, that the vertical fusion, which we say, they will be more than 15, maybe 15 to 25 or something like that. There will be more in case of
Exactly. So what is the normal vertical fusional amplitude? The normal
3 to 5.
is 2 to 3, actually, 2 to 3 prism diopter. So anything beyond 4 or 5 prism diopter, if the patient can fuse after 4 or 5 prism diopter, that means the patient is having large vertical fusional amplitude, and this is go with congenital SO pulse. Okay, this is one. What else?
The other, these muscle sequelae, maybe they're, I'm not sure. I only know.
But spread of comitance can happen with any chronic SO palsy. Either it is acquired or congenital. We can always ask about the old photos of the patient. So that is called FAT, Family Album Tomography. So you can see the patient, the pictures of the patient when he was a child. So if he always adopting anomalous head posture, so that suggests more of congenital SO palsy. Also,
Right.
if the patient is having hemifacial atrophy, so that again will go with congenital
Okay.
superior oblique palsy.
Atrophy or asymmetry? Like the muscles, they will actually get atrophic or just the facial asymmetry?
No, the facial muscles will get atrophy actually because of the long-standing anomalous head posture.
Right, sir.
So yeah, part of the face will be larger than the other part.
Okay. Right, sir.
Okay, great. So regarding the management, as you mentioned, surgical management,
Yes.
what usually the surgery of choice?
Sir, that inferior, so here we know that superior oblique is weak.
Yes.
So we can do the weakening of this superior oblique, and we can we can combine it with the that inferior oblique, because it's overaction. So we can do this inferior oblique recession, and then if there is a large angle of deviation, we can combine it with that ipsilateral superior rectus weakening recession, or with the contralateral inferior rectus weakening.
Yes. So usually we start with inferior oblique weakening procedure, either recession or myectomy. If the patient is having congenital superior oblique palsy with very lax superior oblique tendon, we can do superior oblique tucking, but it's not a preferred surgery now. Usually, most of the strabismologists will go for inferior oblique weakening procedure. As you mentioned, if the angle of hyper deviation is more than 15 prism diopter, you need to tackle two muscles. So inferior oblique is one muscle. The second muscle, either ipsilateral superior rectus recession or contralateral inferior rectus recession to completely correct the whole deviation. If the angle of deviation is less than 15 prism diopter, usually ipsilateral inferior oblique weakening is enough. So
Okay.
it will correct the deviation. Thank you so much, Dr. Hina. Okay, so who would like to take the next case? Dr. Mona?
Yes.
Okay, great. Okay, so I will give you a brief history about this patient. He's 19-year-old male. He had esotropia surgery when he was 5-year-old. And now he present with this picture. So can you comment, please?
The patient on primary position, there is a exotropia, right? Exotropia, around more than 90 or 100 present by the Hirschberg. There is on the right gaze, there is a limitation of the adduction of the left eye. And the left gaze, there is an effect of the adduction in the right eye.
Great.
So,
Yes, continue, please.
and in this situation, in the ocular motility, should do adduction test to differentiate between the pseudo limitation or true limitation.
So to differentiate between if it is true limitation or not, we usually check ductions. Yes.
Okay.
So
Yeah.
to make sure if the patient is having a limitation of a deduction in the right eye, you will ask the patient to occlude the left eye and ask the patient to move the eye to the left side to see if the eye is still not moving or it is moving. And here the same thing. To check for the left eye a deduction, you will ask the patient to close the right eye and move a target to the right and see whether the left eye, will move to the right side or not. Okay, so the deduction testing came to be the same as this picture. So what is your diagnosis? Putting in mind the history of esotropia surgery at the age of 5 years.
Okay, it's most likely because they have surgery of bilateral medial rectus, so could be there is a slipped muscle or Odihens muscle.
Okay, or stretched scar. But what is the diagnosis? What we call this type of exotropia?
Consecutive exotropia.
Exactly, consecutive exotropia, because the patient had a history of esotropia surgery, and you can see here even there is some conjunctival scarring. Here, maybe it's not very clear, but actually the patient had conjunctival scarring over both medial recti. So most probably he had bilateral medial rectus recession and overcorrection happened, and the patient ended up with consecutive exotropia with limitation of a deduction in both eyes. So how would you manage this patient?
After the history and the full examination, anterior and posterior and refraction, and then take MRI to check for the medial rectus.
Okay.
Then for surgery, we do for exploration for the medial rectus first check.
Okay.
And then there is the I forget the name of the surgery, advancement.
Advancement. Yes. Medial rectus advancement. So this
advancement.
Is a surgery. So when you advance the medial rectus, you will do like a strengthening procedure. So that will correct the exotropia. And sometimes the patient might have something called pseudotendon or stretched scar. So in such case, also you need to remove the pseudotendon, stretched scar, and secure the muscle in the original insertion. So that is the medial rectus advancement to correct the exotropia. Other options, what are the other options other than medial advancement?
Bimedial recession, bimedial, sorry, lateral rectus recession, BLR.
Yes, also we can do bilateral lateral rectus recession. But because there is limitation of A deduction, you must do medial rectus advancement. If the patient had consecutive exotropia with no limitation of A deduction, you have the option. You can do either LR recession or medial rectus advancement. But when you are having limitation of A deduction, it is always better to do medial rectus advancement.
Advancement.
Great. Thank you so much, Dr. Mona. Okay,
Thank you.
Dr. Asma, would you take the next case? Dr. Asma? Or...
Doctor, I can take it.
Okay, great. Okay. This, your child came to your clinic. Comment on the pictures.
Okay, on a primary position, the patient is orthotropia.
Yes.
On the right gaze, there is limitation in the right eye abduction.
Okay.
And in the left gaze, the right eye seems to be hyper elevated on adduction.
Okay.
With the narrowing of the palpebral fissure on adduction also.
Okay. And also one more thing. Actually, there is limitation
in adduction in the right eye.
Yes, great. So what is your diagnosis for this patient?
I think it is Duane also.
Okay, so you take the previous Duane case, am I right? Okay, so
Yeah.
I think you will get a Duane retraction syndrome in your exam for sure. So this is orthotropic Duane. That is one way to describe it, orthotropic Duane retraction syndrome, or type 3. Why type 3? Because the patient had limitation of A deduction and limitation of abduction. Both are limited. Okay, so would you do anything for this patient?
As he is in a primary position straight,
Yes.
and if his vision is 6/6, not complaining cosmetically, and there is no abnormal head posture, I will observe him.
Yes, definitely. Such cases, it's better to observe them. Sometimes surgical intervention might cause more problems. So in such patient with orthotropia, mild limitation of A deduction, maybe here more limitation of abduction, but still patient is orthotropic. Most probably he has no anomalous head posture, so no need to do anything. Just observe the patient. As you mentioned, it's very important to check the anterior, posterior segment, cycloplegic refraction, check if there is any amblyopia or anisometropia or refractive error, and give the refractive correction. Otherwise, no need to do anything. Okay. Thank you so much, Dr. Wafa. Okay, let's move to the next case. Who would like to take it?
Okay, sir.
Any volunteer? Okay. The name? Dr. Asma?
Yes.
Okay. Dr. Asma. Okay. So this beautiful girl came to you. This is the primary right gaze, left gaze, right up gaze, and left up. Comment on the picture, please.
Okay, sir. This is a picture of a girl in 6 cases. In the middle low one, which is the primary gaze, it seems to be orthophoric. And there is, yes, it's orthophoric. And in the right case, the both movements.
Orthotropic. Orthotropic is more precise.
Sorry, orthotropic, yes. And in the right case, the right eye abduction and the left eye adduction seems to be okay. Whereas in the left case, there is left eye abduction is normal, but in the right eye, there is exaggerated function of superior oblique. Yes, because it is more in the left case, it is deviated more towards
This
down.
eye is
superior.
right or left eye?
So it says right eye.
Right eye, there is exaggerated superior oblique effect.
Yes, and in the right up case, the eye movements in both right and left eye seems to be normal, and whereas in the left up case, there is limitation of elevation in right eye in adduction.
Okay.
Limitation of elevation in induction in the right eye.
Okay.
Yes.
What else here?
And so in the straight up elevation, the right eye seems to be more towards in an exo position, and there is limitation of elevation too. So if I sum up this thing, so the pathology or the abnormality is in more in the it's in the right eye, and
Okay.
there is in the limitation over exaggeration or response of superior oblique in the down gaze, and also in the up gaze it is lateral rectus overaction
Where? There is no overaction
in
lateral.
the primary elevation, elevation in the primary gaze. So
Okay.
here,
You have
okay.
limitation of elevation in the right eye as well. Here,
Yes.
yeah, I agree.
And
There is V pattern and bit of exotropia,
yes,
but the main issue here is the limitation of elevation.
limitation of elevation.
Yes.
So
And
there is limitation elevation in abduction in the right eye. There is over exaggerated response in the down gaze in the right eye, and similarly, there is inability of the or there is limitation of elevation in adduction in the right eye.
okay.
So seems to be
You will not have that much time and luxury in the exam.
yeah.
You will
So
have around 30 seconds.
I'm
See.
thinking about the right Brown syndrome.
Yes,
But
exactly.
okay,
Exactly. Just say
okay,
it directly. You don't have that much time. You don't have that luxury in the exam.
okay, okay.
It's a small diagnosis. Here we
Okay.
have limitation of A deduction, limitation of elevation on A deduction in the right eye,
Yes,
more in A deduction, less in right in up gaze, and almost normal elevation on A abduction. So
yes,
that is Down syndrome. Very simple. Here we have also downshoot. You can
yes.
see the eye even is not reaching the midline. It is bit downshoot. Okay. In
Okay,
primary position, as you mentioned, patient is orthotropic. So this is a case of Wright-Brown syndrome.
okay.
We
Yes.
already discussed Brown. So just stay with me. We will take the next case. So we will have more discussion. Okay.
Okay.
Okay. Describe Dr. Asma, please.
Okay, this is a colored photo of a fundus photograph of on the left side it is of right eye, and on the right side it is of left eye. And in the first photograph, which is of the right eye, the disc margin, they seems to be blurred on the temporal side, whereas on the nasal side it is fine. The vascular, the CD ratio seems to be I can't figure out about the cup. It seems to be a relatively blurred margin, so I can't comment on the cup and on the neuroretinal rim. And the vessel arcade coming from them seems to be like a bit tortuous.
Yes.
And on the on the macula, there's pigmentary changes are seen. I'm not very sure of it, but there seems to be pigmentary changes. However, in the periphery, I can't find any pathology. And if I comment on the other eye, that is the left eye, there is peripapillary atrophy, marked peripapillary atrophy, more towards the temporal end. And again, in this case, I see the disc even seems hyperemic. And there is also in this along the vascular arcade, there is a sheathing of the vessels.
Yeah.
Yeah, and the macular appearance is same as in the other eye.
Actually, in this picture, I think the photo is focused on the optic nerve. Because of that, we cannot see
Okay.
the details of the macula.
Yes, sir.
So, so
So,
what
so
do you think, what it could be, the diagnosis?
that
Again, this
I
is spot
yes, sir.
diagnosis.
It can be because they are sheathings of periphlebitis. I'm going more toward vasculitis and more towards periphlebitis.
Okay, but the vessels are totally normal. I agree there is a bit of sheathing or that we can see the reflection here of
Mm-hmm.
the ILM, but actually it can be considered as normal, I think, but it's considered as normal. We have tortuosity of the blood vessels in both eyes. I agree on that. Otherwise, the retina per se, there is no pathology.
Mm-hmm.
The pathology in the optic disc. So,
So the
what do you?
pathology seems to be because there's a pigment, there is around the disc, there is pig. So it can be nevi at the optic disc or melanoma at the optic disc, or it can be peripapillary atrophy too, or it can be. Uh,
If I told you this is a bilateral pathology in both eyes, what do you think?
so in that case, I can't see any myopic changes, so I can't comment on that. And if it can be it seems to be a bit tilted also.
Okay. But
And
what about the size? The size of the disc?
size, these are small hypermetropic. So it can be optic nerve hypoplasia too,
Yes.
if you think of it, because they can be the double ring, especially more marked in this uh, left eye fundus photograph.
Yes.
Uh,
Sometimes you might get the double ring sign, sometimes you don't have it. But there
it
is one thing that will help you in deciding whether this is optic disc hypoplasia or not, to
Yes,
compare the full size of the disc and to
with
see the distance from here, from the temporal margin of the disc to the center
fovea.
of the fovea, and
Yes,
see
sir.
if it's more than 3 disc diameters. So this is optic disc hypoplasia. And
Yes.
we can see here the figure out the fovea maybe here.
Mm-hmm.
So definitely it is more than 3 disc sizes. So
Mm-hmm.
this is a case of optic disc hypoplasia.
Okay.
So how those patients present?
Okay. So these patients, I think they have got because it's the optic nerve hypoplasia, so it has something to do with the angle cap, a positive or negative angle kappa. So I'm not
No,
sure. Maybe.
actually,
um,
this is not a strabismic case. So
Okay.
usually those patients, the visual acuity,
They have
sometimes
nystagmus. They have nystagmus.
yes, if they have very poor visual acuity, they will have nystagmus. Sometimes they have very poor visual acuity, like light perception or counting finger close to face. Sometimes they have subnormal vision, maybe vision 612, 6:9 in
Mm-hmm.
some cases. Okay. So if they have very poor vision, they will have nystagmus, they will have esotropia in some cases, and in some cases there will be good vision, as I mentioned. That is one
Mm-hmm.
thing. Secondly, some patient will have RAPD.
Yes,
Some
sir.
patients with bilateral cases will have sluggishly reactive pupils. And then we have the ocular and the systemic associations.
Yes.
So what are the associations?
So with optic nerve hypoplasia comes the of ocular association. We think of can be albinism, and it can be a microcornea, microphthalmus, and in a systemic one, what I can think of is the young maternal age or the use of certain medication in the first trimester, and there can be uh,
There is one common systemic association that called septo-optic dysplasia, de
G.
Maussier syndrome. And
Yes.
sometimes those patients might have developmental delay or some hormonal disturbances.
Fine.
Okay. So yeah, here are the whole summary of what we have said. So risk factor, it might be unilateral or bilateral. Young maternal age, as you mentioned, primiparity, maternal exposure to various agents. It might be isolated or associated with systemic disease. Symptoms, either severe bilateral cases will have blindness in early infancy with nystagmus, or unilateral or less severe bilateral might present with a squint, and mild cases are easily overlooked. Signs, visual acuity ranges from normal to severely impaired, RAPD, sluggishly reactive pupils, and then this is the fovea disc center distance of 3 or more times the disc diameter strongly suggests hypoplasia. The vessels are sometimes tortuous, and the double ring sign here, it is shown. The double ring sign, you can see, this is the disc, and around it there is atrophy. So that is called double ring sign. Okay, thank you so much, Dr. Asma. So who will take the next case?
I can take Dr. Hina.
Dr. Hina. Okay, just yeah, that is about the same case. Ocular association with optic disc hypoplasia, astigmatism, amblyopia, field defects, foveal hypoplasia, aniridia, microphthalmus, and systemic association, developmental midline brain defects, pituitary and hypothalamic deficits, and septo-optic dysplasia. Investigation, all affected children should be screened for systemic associations, especially hormonal deficiencies and developmental delay. So that is about the case of optic disc hypoplasia. Now, Dr. Hina, comment on this picture, please.
Okay, this is a fundus photograph. I can't comment is it right or left because it's mainly focused on the optic disc. So here, basically the vessels, they are arising from the center and going all radially. So not like in a normal fashion. So, and there is this peripapillary atrophy, and there is a deepening of the this optic disc. So it's more like looking like a morning glory.
Yes, exactly. That is a morning glory disc. So, what are the associations with morning glory disc?
It's a faces syndrome. That's what is coming in my head. It's associated with this capillary hemangioma and the posterior fossa malformation. There is also this aorta's coarctation, cardiac anomalies, defects,
The
faces.
charge
Yeah,
syndrome.
HR syndrome as well. Yes.
Yes. And what do you expect in this patient, the visual acuity? How do you expect the visual acuity in this patient?
Must be yeah, definitely it will be worse than 660. So maybe counting finger or even
Yes.
like that.
Most of the cases, the patient will have poor visual acuity. I agree. So this is one of the optic nerve anomalies that might come in the exam. And as you mentioned, systemic association frontonasal dysplasia and basal encephalocele, sometimes associated with pituitary insufficiency. Uh, Visual acuity, mostly what I have seen impaired but in Kansky, it's mentioned maybe normal in some of the patients. Okay, so all these text from Kansky. Complications, very importantly, serous retinal detachment in 30% and choroidal new vascularization. Okay.
Yeah.
Thank you, Dr. Hina. Okay,
Thank you.
who will the next case? Any
Yes,
volunteer?
okay.
Okay,
Yeah,
Dr.
I'm
Comment on the picture, please.
posterior segment photo, colored photo of the right eye. There is optic. There's a optic disc defect. Enlargement mean there is optic disc coloboma.
Yes.
And there is normal blood vessel distribution, and there is a lesion in the macular region.
Yes, it looks like hyperpigmentation in the
Yeah.
nasal part of the macula. Yes, great. What about this picture, Dr. Muna?
Yeah, there is a large optic disc with a pigmented margin, and there is optic disc bit.
Yes, actually, this
there
is optic disc coloboma with optic disc pit. Sometimes optic disc coloboma associated with optic disc pit as well. And what about this picture?
I think there's even the optic disc coloboma.
Yes, yes. So all those three pictures, optic disc coloboma, I just get those three pictures to show you that there might be many pictures of the same pathology with little differences. So the message, you need to see many pictures of each anomaly because unfortunately, usually we do not see much of these patients in our clinics. You might see only one case in your residency, for example, or in 10 years of experience, maybe one or two cases. So you need to see a lot of pictures of each anomaly. So if you have it in the exam, you will get to know it. So you can see here that colobomatous disc here, it is very obvious. Okay, Dr. Muna, so what are the associations with optic disc coloboma and the complications?
It could be associated with the choroidal coloboma or iris coloboma.
Yes.
Or associated with the systemic heart disease.
Yes,
I'm
golden
not
heart,
sure, but yeah, I think
Church syndrome also can present with optic disc coloboma. And if optic disc coloboma associated with optic disc pit, the patient might get also serous retinal detachment from the optic disc pit. So here are the summary. So the embryonic fissure of the developing eye is located inferiorly and slightly nasally and extend from the optic nerve to the margin of the pupil. Because of that, some patients might have only iris coloboma, some patient will have iris with optic disc coloboma, some patient with retinochoroidal coloboma as well. And coloboma is a defect in one or more of the ocular structures. It might be unilateral or bilateral and sporadic in otherwise normal individuals. And sometimes it is associated with systemic problems such as the Charge syndrome. This is the Charge syndrome, golden hair, and central nervous system abnormalities. So actually Charge associated with optic disc coloboma, not morning glory. I'm sorry. I did a mistake here. So regarding the charge, here are the letters. So C for coloboma, H for heart defects, A for atresia coena here, and R for retardation of growth, G for genitourinary abnormalities, and E for ear abnormalities or deafness. Okay. So in patients with optic disc coloboma, vision is often decreased, amblyopia refractive error may be present, and patient might have a disc pit as the last picture, and ocular associations, microphthalmia, microcornea, globoma of other structures, and complications, serous retinal detachment or progressive neuroretinal rim thinning and choroidal neovascularization. Okay, thank you, Dr. Mona. Okay,
Thank you.
I with my presentation. Anyone has any question? Any questions regarding the cases that we discussed together today, or any doubts about any strabismus case you have?
Sir, can you explain in nystagmus the use of prism, especially in congenital nystagmus? Why we prescribe this in like base out?
Okay,
Yes.
sometimes nystagmus will dampen on a deduction. So
Yes.
sometimes if you give prism, you will put the eye in the adduction position, so the nystagmus will dampens. So
Okay.
sometimes in patient with nystagmus, we might prescribe prism.
Mm-hmm.
Yes.
So it means like converge the eyes, or if we are giving base out?
So actually, you will put the picture where toward the apex.
Okay.
So the eye will the nystagmus will dampens.
Mm-hmm. Right.
Okay.
Yeah. Thank you, sir.
That is of the management for the non-surgical management of nystagmus. There are many other things like contact lenses sometimes might help. Why contact lens help in nystagmus patient?
By correcting the refractive error?
That is one thing. Secondly, because of the proprioceptive receptors on the ocular surface.
Okay.
So sometimes they say in some cases contact lenses, but again, it's very difficult for an nystagmus patient to wear contact lenses. Other things, sometimes medical management can be used like brinzolamide eye drops. Some patient might benefit from brinzolamide eye drops, and some systemic medications mostly are neurological medications like memantine and other medications that sometimes can decrease the amplitude and the frequency of nystagmus, and the patient might benefit of.
Sir, you mentioned brinzolamide. So how will it affect that brinzolamide?
Actually, we do not know the mechanism till now,
Okay.
but it is mentioned, and it is effective in some patients with nystagmus. Actually,
Mm-hmm.
I'm talking here about congenital motor nystagmus. So in some patients, it is helpful. Okay, but till now, no one knows what is the mechanism. But Dr. Richard Hertel mentioned it, and there are some studies about this. Otherwise, in nystagmus patients, we can do surgery. Many surgeries are there. One of them is tenotomy and reattachment of the muscles. And that is again related to the theory that
Yeah.
yes, the proprioceptive receptors.
Okay, right, sir.
Yeah. So we do just tenotomy. You disinsert the horizontal recti and then reattach them again. But unfortunately, recurrence rate is very high.
Okay.
So some patient with nystagmus and they have null point in one position. For example, patient with nystagmus, but in right face turn, he has a null point, or
Okay.
the nystagmus dampens. So we can do either Anderson procedure. We will do recession of two muscles, one in each eye, or we can do Anderson-Kistenbaum procedure, where we will do recession resection in both eyes.
So the
So
difference between the two is in one we only do the recessions. Yeah.
Anderson only recession. in
Okay.
each eye, one muscle.
Okay.
In Anderson Kistenbaum, we do recession resection in both eyes.
Right. Yeah. Thank you, sir.
You're welcome. Any other question?
Thank you, sir. Thank you so much.
Thank you so
Thank
much.
you, Dr. Omar.
Yeah. Thank you, sir.
Thank you so much, and see you soon in other classes.